is more important for those institutions where we find accreditation plays a major role in changing the quality. So once again, to start with the NPTEL learners, very good afternoon. And for this case study live discussion session, I welcome to all of you. The topic for today's case study is about a private tertiary care hospital in India dealing with NABH accreditation standards. Myself, Dr. Dhananjay, presenting to you about the issues which an NABH accreditation hospitals usually takes ahead for. So today we'll be discussing about the real world issues pertaining to this study and making it more into the complexities which quality management in Indian private hospitals faces. So we will be taking you through the entire presentation with giving you an introduction about the quality dimension, the accreditation imperatives, about the hospital's background, what the hospital is particularly over there, what is the profile, different departments and patient loads. The accreditation status, what this hospital particularly have, and currently what the hospital is having, the major issues the hospital is facing with respect to the clinical safety, HR, and the operations, infrastructure issues, and finance part. With respect to applying the quality framework, and before that, what the root cause analysis has an importance with respect to the system. What are the reasons? What are the failures will be identified, and the quality management tools, which are more coming for pro towards NABH, the domains, PDCA, Six Sigma, all that will be discussed. The solutions for this issue will be identified with respect to the evidences. Evidences which are coming from the multi-level problems. The problems might be coming from administrative lens, might be coming from clinical, non-clinical, or even ethical problems will be stated over here. Impact of this and how it will relate actually helping you to your own institutions and the problems that you are trying to deal with the quality, especially to those institutions which takes more issues and exploration with respect to quality and cost. How does quality is connected with cost, that will also be discussed. In introduction, I would like to state you that this study is more about the quality imperatives. And as you all know, how private institutions are more into a pro approach towards accreditation, which makes private institution more remarkably changing their own philosophy towards understanding the quality. What makes them to understand quality and what quality finds actually as an issue to make these institutions more responsible for quality part. So quality imperatives for hospitals identifies a role not only for tertiary care setups, but even from the primary, secondary, tertiary, and even quaternary level. When we talk about hospital as such, here we will be discussing more about a tertiary care setup hospital, and the management issues here will be more to be seen with respect to the modern hospital administration, where it is more particularly pro towards a patient's approach, where it is more like you will be making it more clear through the structure, process, and outcome model. Particularly in private tertiary care hospitals in the metropolitan city, where there are a lot of internal as well as external factors which are more responsible to make this as a very important in discussions. These hospitals, private hospitals, often demand, or they are more often advanced with diagnostic and therapeutic services, where diagnostic plays a very major important role, and thereby the private sectors are more contributing towards more screening part, understanding, exploration, advancing disease conditions are also being seen as a major scope to be treated. And thereby the services are more towards a diverse group of population, might be from poor to the middle income and to affluent or elite population, richer population. These institutions are operated under the high patient loads because of the demand and the quality services that are provided. And that's where we find the shape that most of the private institutions are majorly taking role in catering the services to Indian patients. And even the competitive pressures makes them more towards quality and to seek quality. So we have a question over here, why quality management matters over here? And what is the reason that these institutions are making it more towards to think about quality? And what makes uh, this institution to take the challenge of quality? Where we find most of the reasons which institutions think for quality is more because of medical problems, that is the medical care. And in that, most importantly, is the medical errors. To reduce the medical error, which is the leading cause of mortality, morbidity, which is increasing in number, as well as mortality, which is the final challenge actually, which medical errors are taken responsible for. As it is stated by the WHO data that every 10 out of 1 death is more being caused because of hospital death, and the major reasons of this is hospital infection. So most of the preventable medical errors can be something which can be treated with quality, and quality is an absolute answer for that. Also, the high patient expectation, which demands a consistent evidence-based clinical outcome, which is somewhere or the other, it is more that quality is being a need which is being pronounced by the patient. The patients are also expecting, and the demand of the patient because of the cost, because of the expectations of understanding the system, and also knowing the repercussions, like how the clinical outcomes are affecting the life. Additionally, the regulatory and accreditation frameworks that a hospital adopts, whether it is an NABH, JCI, ISO, or in NQAS also, that we have discussed in the previous case study, where you will understand that how this will make a quality benchmark where the hospital has with the competitive edge, or even taking this from one department to other, or progressing into the first cycle of quality management, and taking this ahead. The regulatory and accreditation framework measures the thing that how these quality benchmarks are achieved by the hospitals or not. Also, the quality management matters over here is more because quality management activities reduces the liability. It also builds reputation and improve the revenue. So it is more benefiting to the hospital also. Hospitals also flourish. They develop, they gain an image, they set up a reputation in the society, which makes more patients to come. Follow-ups becomes more proper. Services are, so ultimately the service health outcome is improved, increase. And so where is related to the revenue improvement of the hospital. The hospital also seems to earn actually because of quality. Also here, the major question that quality provides and the larger benefits for sustainable health is more towards quality ensuring equity, where we discuss more when we talk about health equity, that it is more reasons that health inequity comes because a consistent, a sustainable, and measurable level of care with respect to the vulnerable population, ethnic group of population, people with disability, where biases towards the gender, and migrants population, all those deals with in comparison to the equality which is necessarily being seen, is to be seen in healthcare is not provided. So where the concerns are mostly addressed inconsistent with the respectable care which is expected by different patients or patients from different demographic, where it can be issues from age to sex, to regionality, to the different demographics, to the income groups, and all those which identifies to come into the social determinants of health. Okay. So this is one very important part that we need to take it in. What are the different dimensions of healthcare quality according to the Institute of Management, Institute of Medicine, and WHO World Health Organization framework spells over here? The very important issue that quality, when we talk about the definition of IOM Institute of Medicine, which makes it more clear to us in understanding how quality takes its major shape when we understand the different dimensions of quality, which is more to be very included, or I mean to say, needs to be inclusive in every healthcare quality management policy document, while understanding the processes actually that we are more as a practitioner who are working, medical doctors who are more into the clinical interactions, which are more towards the better clinical health outcomes. So the 6 dimensions that are more important over here, where it more leads to come from the Donabedian framework, which is more towards the core concept of understanding the structure, process, and the outcome, where from the infrastructure to HR to equipments, even from the care delivery methods, the um, issues of departments like OT, ICU, or even non-clinical department like CSSD, MRD, and all those are more dealing with understanding that the quality managers, the quality professional should understand towards the beneficiaries or towards the customer, that are the patients. The very first and very important dimension here lies with the safety component, the effectiveness, the timeliness, the efficiency part, and the equity. So when we talk about patient safety is a sub-facet of quality. Although otherwise it is very important to see that how quality reflects is more when we try to get the patient safety. Where it is very important that patient safety is preventing harm from care delivery and zero harm culture, where there is, when you do no harm to the patient, is what patient safety keeps us up. So patient safety is one among a very important dimension or facet of healthcare quality. Then comes the effectiveness, which is very important to be seen when we talk about the evidence-based interventions that produces intended outcomes where you can see, you can measure, which is more to be seen in those practices where we try to give an evidence of the healthcare initiatives that we take, interventions that we take, which are measured through tools like Six Sigma and all. Even quality dimension, one among is the timeliness, which is reducing the delays, harmful delays, which are making the patient as well as providers more delayed, and which creates a major issue of morbidity, and which also sometimes extended delays can lead to mortality. Efficiency is also being counted as an optimal use of resources without waste, where wastage or reduction of wastage is very important to be seen when you have to see the issue of improving the efficiency. Equity, already we have spoken, that is consistent quality regardless of the demographic, regardless of the vulnerability, regardless of the issues that are more pronouncing towards the major parts which makes every institutions to be more towards providing the health equity. Patient-centeredness is the very important and the sixth and final dimension, which is more towards understanding the care that should be more respecting a comprehensive care which is more focused towards the patient and individual preferences which are valued, which are respected, and the decisions for the care, the medical interventions are made according to the patient's need and not ignoring the patient's. Now coming to the core issue that this case deals with. What is this hospital that we are discussing about, this particular private hospital, and what is the profile that we have taken this hypothetical private tertiary care hospital, where the hospital is stated to have a certain set of a problem. The problem majorly comes with these hospitals are not only because it is of a location which is based into a metro city. Ideally, we can take that this hospital is located in city like Delhi. We may have three different uh, hypothetical cities that we can put it, and we can discuss this how it can be if it is location is in Bangalore or Delhi or Mumbai, how you can see the affections of quality or the quality imperatives will be there. If you are taking among this, like out of all these three or four major cities, if you choose even a Delhi and we are putting it that this hospital is a hospital which is a private multi-specialty tertiary care hospital, which is providing all sorts of services actually which are more towards the prone need of those patients who are set up into the urban population, majorly concentrate towards the urban health needs. And where the patients are well defined to approach these hospitals because of the cost and the affordability that this hospital is providing. The hospital is making more needs towards strengthening or improving or increasing the facilities by providing through different department and making that major of the department that the hospital is being counted this particular hospital XYZ that we are putting over here from the Delhi city is more that the hospital is providing some of the services which every hospital has, that they are more being popular. So for this particular hospital, the services are like emergency department, ICU, their cardiology unit, the oncology, orthopedics and radiology. So you can understand it's more towards the regular communicable disease, and additionally non-communicable disease burden is more being taken by this hospital. This hospital is 350 bedded plus, and the hospital has general, semi-private, and even ICU categories, where the hospital is meeting the requirement that all the setups this hospital is meeting towards the tertiary care requirement. The hospital usually gets a footfall of 800 to 1000 OPD patients per day. So you can understand there is a need that is being spelled with this profile. And the ownership is more like a corporate healthcare group who has owned this hospital. They are making all the provisions, making it as a setup which are being seen to be very well protected in terms of the financial support. If you take the market position of this hospital, the high-end tertiary care under intense competitive pressure, whether in the vicinity or even in the city, there are many such hospitals who are more or less similar towards the provision. In individuality, what differences makes this hospital from those hospitals that we will be discussing now. The services like advanced diagnostic, robotic surgery, transplant services, these are something which are more prime if you take the specialty of this particular hospital, and which makes this hospital more like a hospital of something as an importance, which gives the hospital a reason that this makes the hospital something different from the others. Now we'll try to understand the departmental overview and staffing. Okay. So when we try to understand what are the issues that this hospital usually makes up when the departmental level or the staffing issue come, and what are the gaps the hospital goes on. If we have to talk about the hospital through an NABH lens, and if we make that how NABH, which is more meant actually to understand the Indian specific standards or Indian specific hospital need, where you find JCI is more towards the international benchmark, which is more very stringent and very costly affair, where NABH is more focusing towards patient safety and continuous improvement. So if we talk about this, the clinical departments over here as emergency and trauma that is being provided 24/7, and critical care. ICU is there of 40 critical beds. Cardiology, cath lab with interventional services are one are being seen as need, and not only being need, but the number of beds, and in proportion to that, the need of the cath lab which is being spelled is also provided. Oncology setup, orthopedic setup, and radiology setup, which has their own individual specialty, are also being seen as some of the prime departments which they are full fledged and flourished. In addition to that, there's every hospital requires the support and utility services. This particular hospital is also having support and utility services, which is primarily after CSSD and all. Pharmacy, which is more a central and satellite dispensing unit, which is very much one which is uh, one we have major of among the service division, which is being seen as very primarily highlighted for this particular case. Laboratory services, biomedical engineering, which identifies to cater the support and utility services requirement, which are also being. The quality department, the quality management team who has taken the challenge of implementing and executing actually the NABH requirements and making the hospital more NABH compliance with respect to internal and external quality audits, and having their own quality circles, which is making this hospital more towards a pro approach of quality department, where the NABH compliance is something the hospital is more focusing. If I have to talk about the human resources for this particular hospital, it is 1200 plus staff, which is uh, altogether very much sufficing actually towards the need, not to specifying but it is overall, we can say it is meeting. If we talk about the multi disciplinary work actually, or to take different challenges, how this healthcare workers are being are being trained in the private hospitals. So for that need, support staff is well equipped, well developed. Finance, insurance, billing, and revenue cycles are being seen that the hospital is taking ahead properly and has more or less actually an understanding that the hospital is more towards developing the ecosystem that the hospital is having is more towards quality accreditation needs. The comparative scenario is where we find that NABH is being seen something which is little moderate in terms of the cost part compared to the JCI where it is high, and applicability it is more like Indian hospitals. Slowly now NABH is more even moving outside of the country and also being seen as even projected towards even our government institutions are also trying to. But a complexity which makes NABH or even any accreditation system always, when we talk about to make it acceptable versus non-acceptance. The major issue is of adapting in terms of like adapting where the national quality services or national quality initiatives which are being seen by ministries, different international agencies, and all those makes it more imperative actually that quality is something like the hospitals are thinking as future. So when we talk about NABH, which also comes under the control of QCI, Quality Council of India, and NABH is the India's apex body for setting quality standards. And not only the standards actually, which are being spelled actually into the Clinical Establishment Act, but even the accreditation for the healthcare organizations. May it be purely that private is more pro towards NABH and government is something like which is more driven towards the needs of NQAS, that is National Quality Assurance Standard, which is coming in support from NHSRC under the Ministry of Health and Family Welfare. NABH was established in 2006 as a constituent body of the Quality Council of India, and the constituent body QCI made the NABH, which is recognized by ISHCA, the International Society for Quality in Healthcare. And what lies to make NABH more different and to make it more that since the NABH has taken so many 15 plus years of Quality Council of India becoming very important role making in identifying and giving the revisions of the different standard, and the latest what we have seen, the fifth, which is being seen as par excellence to the international standards. If I have to talk about what NABH covers, NABH not only covers hospital that we are discussing, but along with that, NABH covers labs, NABH covers blood bank, and NABH covers also clinic and even Ayush clinics also. NABH is being seen as a voluntary accreditation with rigorous assessment. That's what I say. It is like a moderate level of complexity, especially for quality management that NABH gives you. And this makes us more reasons that when we talk about NABH, there are 10 standard domains which are covering the clinical as well as organizational functions. What makes institutions more reason actually for us to think about quality when it tries to take this first as a challenge which comes at a hospital level, then at a department level, and then at an individual level, where all clinical and non-clinical level people are involved. When a hospital starts to take as a cycle for the NABH, it is more to be seen that the initiatives are born driven with a quality team, quality circle, quality team, quality management at a authoritative level, departmental heads, HODs, and all. What comes to state that, like after seeking an accreditation, getting the certification, what is the renewal process? The renewal process for NABH is every 3 years with surveillance audit. So it is being seen as the quality audit plays a major reasons actually to see that you get a success into your surveillance audit. Which why though it is being always spelled that quality is an everyday work. It is not that it is once and achieved as a quality will remain as same. No, it's not like that. It is more that quality is a continuous and regular effort, and every time you have to make the same level of thing that what we are doing it for quality to achieve it at a level of excellence. Now, at the current time, most of the people are well versed who are already in practice in quality and who have taken NABH as an major reasons to start with quality and has been following and making NABH as a very important national quality initiatives and have made this not only for private hospitals but also an often adopted framework or a similar framework which is being seen to be coming into the government institutions also. So fourth edition was something which made a great opening, eye-opening actually to most of the quality issues. And later, the fifth edition, which is the latest and currently very operative in terms stating that the facts that NABH try actually to fulfill the International Society for Quality and Health Care and making it more an issue which is more understanding for dealing with the not only the cost but even improving the health outcome, which is more that we have seen that lot of clinical variability or we can say disparity actually also comes with major of the issues which are aligned to administration, where clinical and administration most of the time are being seen very hand to hand. And as NABH undergoes a rigorous NABH accreditation process, it not only takes time but even preparing, planning, then the process, the actual one, and the outcome, and again evaluating the failures. So when we talk about PDSA, plan, do, select and act, where versus the PDCA where the plan, do, check and act, which comes as the second line of a cycle where you may have to repeat it again if your hospital or your team or your efforts are not matching to the requirement that a hospital is expected to develop and evolve. Adherence to the standards across the patient care, infection control, medication management, and facility safety, which is more towards spelling about there should be uniformity in provisions of the expected improved standards. So the structured protocol, SOPs, and clinical pathways in line or in place will make more the hospitals more prepared towards NABH. Regular internal audits which are done by the quality team, the mock drills which are preparing the hospital to get more resilient towards the quality management issues, might be a patient safety, might be a disaster, might be something which may come as an even a man-made or even natural disaster. Kappa cycles which makes the hospital more responsible to improve the clinical outcomes actually, which are one among the reasons that hospitals take Kappa cycles to see that institutions are more built when you are taking more audit. EHR, which is a very interesting and very important topic to be discussed over here with respect to the structured documentation, which is one among the reasons that quality has boosted, or I mean to say that EHR came into more focus only because of the quality evolution. And now when we are more towards the developed part of that, that is EMR, that is electronic medical record, and EHR, which has given more reasons that hospitals are making patients more uh, towards their own responsibilities of taking EHR with a structured documentation, and hospital themselves have to also take initiatives to improve the HIS part of this. That's a health information system, which makes more reasons to reduce the vulnerability, to reduce the uh, inappropriateness, that more results to the health, poor health outcome. Then comes the reasons why NABH has more concerns towards the patient. Is it like patients have more benefits from NABH? Ideally speaking, the patient rights ensures, particularly for the part when NABH is being more spelled, that informed consent, grievance, redressal, and privacy plays a major role when you see a hospital who is or has an NABH accreditation. The reason to state over here that NABH tries actually to see that the quality comes through the lens of a patient. Quality gives more reasons actually to the grievance that a patient has faced, and the issues with respect to confidentiality, privacy, anonymity are being taken. So where we can say it's like a more patient driven and ensuring the patients that their rights and responsibilities are preserved. Then comes very important, that is infection prevention and control, that is IPC committee actually. IPC committee is one which is a very mandatory and very important, even though not only for quality, but it is very important even to reduce the burden of infection prevention and control, where prevention comes first and control comes next, where after establishment you can even see that it should not deviate, then the control also issue comes. And infection prevention and control committee is more constituted by all the heads of the department, medical superintendent, nursing matron, and even a dedicated quality manager for them. NABH also seeks the trained staff on NABH standards and periodic competency assessment, which is one reason that NABH gives more emphasis on even training of the NABH part. Okay, so what will be NABH training be more important? It is like a periodic, monthly, 6 monthly, with respect to all clinical, non-clinical, like heavy loaded, moderate, average. So all departments are to be put under the regular way, like how this NABH will be seeking upon, which makes more reasons that institutions which are being stated to take ahead this as a quality will also try that institutions come up with the competency assessment, which will always try to give more benefits or age that quality has stated upon, or quality has given something as a benefit and also being seen as an edge ahead actually to the competitors. Now comes even the role that NABH, with its more emphasis, NABH being more responsible to keep up clinical committees as very important, because you need to understand through your causes, you need to understand through the pending issues, you need to understand your challenges, and clinical committees focus their work mostly on mortality review, pharmacy and therapeutic uh, reviews, and issues of patient safety, sentinel event, near miss event, adverse event. Okay. And quality indicators that are tracked with HAIs, that is hospital associated infection or hospital acquired infection, medication errors, patient falls, or average length of stay of a patient. So the quality indicators are playing a very important role in those NABH accredited hospitals. And so where the standardized system approach is very, very importantly being seen in NABH institution, which is very evident if you go and see an NABH institution which has already received the NABH accreditation. Now we talk about the unstructured way at hospitals. Sometimes when a hospital is non-accredited, what will happen? Is it like the unstructured processes and inconsistent quality practices will be seen at the very first? Ideally speaking, no. It will take time when we identify the risk, like without accreditation hai, and your hospital is having a major quality problem, that on the all there are patient safety to system failures to lack of provisions, and even to be seen as a non-continuing activity, NABH comes very importantly in comparison to the hospitals which are non-accredited. That is, the institutions which are non-accredited lack more into the standardized clinical and administrative process. As if like the clinical process has no accountability and effectiveness with respect to the works over done. And so is being seen in administrative process where there is a lot of delay and disagreement, a lot of litigations, violations, which makes more administrative process difficult and the compliance part is very poor. Quality practices vary widely between departments and individual practitioners, which makes sometimes little challenging that you may find a quality management practice which might be taken by one particular department very properly and the other particular department even makes the hospital in shambles. So where we find quality can be seen as an act actually which is more by a teamwork, by more specifically stating uh, that it is not being coming only to be seen by one individual person as a choice and all that. It's more like an intersectoral activity which is being taken as a teamwork. Additionally, for non-accredited hospital, no formal incident reporting or adverse event tracking system is being seen, and which makes more reason that if you have such an ill practice, how would your hospital survive? How would the hospital being seen to take the events seriously, whether it's a very preventable event called as a near miss event, or a very fatal or unpreventable event that is called as sentinel, or what I can say, adverse drug reactions, ADRs, and adverse events, which sometimes leads to mortality. And many times it has been seen that it increases the morbidity or puts you to major questions that if at all this is not rectified, how it ultimately leads to the fatalness. Documentation is inconsistent and often retrospectively completed, which is sometimes making institutions more reasons to take care for anybody. Infection control practices depend on individual awareness and not institutional protocols. This has been also being added as a very important reason for non-accredited hospitals having a poor versus two accredited hospital a richer edge actually in patients selecting the hospital. Private identification relies on manual and error-prone system, which makes hospital to think that the patient identification rule is very, very important, and patient ideally should be the first hand identified with the unique ID number. Non-structured performance appraisal and quality linked incentives, which will make the employee more accountable. Something like a very good HR practice, which comes more from the quality part. Limited infrastructure empanelment due to lack of accreditation status is something that a hospital can lead, or the hospital can get it from the consequences if they are not trying to fulfill themselves for quality, which makes more reasons that you may have lot of duplicacy, fraud, or even corruptions which are more coming with the insurance, which most of the hospitals are also trying to safely handle this. So, and additionally, no formal patient rights framework concerned, may be informal, where the patient rights and responsibility charter is released, but no formal patient's rights framework is one which is not being established to be seen, and we have to take help of the small guidelines or some materials the government is providing, and with that, Indian hospitals are running, which is really, really very commendable efforts that the hospitals are taking ahead with. Signing staff actually, which makes more reasons that the institution is more towards understanding the issue of staff training as a prime priority, where the skills, the development, and the safety protocol always lies. I'm not keeping something that a regular employee does very good or even ad hoc come less. It is more like how you are training them. It is more that how you are motivating them, and it is more than how they are taking it in terms of the efficiency, how it is working, very, very important. So that plays a major role in identifying and making it. Now we'll try to understand the key operational and clinical differences, as we have already covered the NABH accredited, non-accredited hospital. But just to quickly make you run through the presentation and to make it more clear, like how we can differentiate when you take this case study, as this case study is particularly as an NABH institution case study, and one case study if you are reading of NQAS or even JCR, what are the differences that we need to understand over here is very, very primarily very important. When we talk about NABH accredited institutions, which are more like a standardized institutions, which are more towards the standard operating procedures, where for the employees, the clinical and non-clinical, and even the clinical pathways are also being very, very clear, which makes these institutions more reasons actually that they are more towards an quality philosophy. Okay. But non-accredited, actually, who are on verge, actually are making more pressures actually to the employees, where there are ad hoc processes, departmental dependent quality, and sometimes it also deals with the committees issues or their challenges, which might be coming that sometimes if the committee is there, but the committee is really not active, or no surveillance is there, or manual ID system, which are prone to have a lot of mix actually, which makes us more in advance or sometimes very poor part. But the barcode based patient identification becomes very, very important, and you find that a lot of ethical issues can be handled if you are trying to make this one problem to be solved in the hospital, where the hospital is more prone actually to create more issues because of only identification. So barcode-based patient identification, LASA, that is a look-alike, sound-alike drug, where a lot of prescription errors, medical errors, dispensing errors are coming more because of the safety protocols that are not followed, which may be always by double check or confirmatory or checking the expiry names, generic names. Now, those are very, very important. And even spelling it, confirming it to the patient, which makes more reasons that you may not come across these issues. No formal medication safety is being seen in non-accredited hospital, and the manual that you talk about quality is nowhere seen. Or many times you may find the people who are into the clinical work actually sometimes take it very casually actually to those approaches which comes as major adverse event, and they really don't come with the mind, and their work very much increase. So we need to change this, and there is a structured incident reporting, which is giving us the answer that why we need to go for a root cause analysis, and what will root cause analysis give us. As I stated previously, that EHR and with clinical audits or audits as such are improving and making the operational efficiency part more good into the NABH accredited hospital. Insurance empanelment equality eligibility, which makes more that a person has done or has completed actually his uh, specialization in quality, who has already come up with the training which is being provided by NABH of the 3 days or 5 days, that is from the POI actually towards the assessor part, internal and external quality assessor, and insurance empanelment eligibility, which makes the institutions more towards the cashless, or we can say health insurance. And you may find that institutions which are accredited with the hospital, you may not get more problems actually with cashless health insurance patient, or sometimes they may say that our institution is not a panel. In that way, any which institutions ideally cannot say this. Then comes on the other part of the non-clinical, it is more towards adverse events under reported or ignored, which might be because of the culture, or sometimes the hospital may feel that there will be a lot of punitive actions which will be taken by the municipal corporation, and so where they are trying to do. But usually they may have even lot of, because of huge error, they may even ignore or sometimes underreported our parties are being seen as. So, what are the reasons that we need to improve this? We need to see that these institutions should go for a regular, informal training sessions. Why I'm saying regular means regularity is connected with quality, where irregularity and informal trainings are something which becomes more lesser part actually to give a reasons for that. Paper records with documentation gaps, again for the evidence-based practices, and to show up to the work actually that you have already met with, or you can comparatively analyze with the work of other practitioners outside the world. Limited insurance partnership is for those institutions who are in a very nascent stage or who have not accepted or who are only trying to develop the institution in cancer or something, they might be having a different set of an agenda. So insurance limited partnership is one of major problem. Now we will come up with the major 7 issues that are pertaining with the quality issues. And what are those quality issues in this particular hospital? If you try to come up with the different categories, the 7 categories that come to my mind, particularly for quality challenges in private tertiary care hospital, is also being more or less seen. So, what are the major quality issues for this particular case? The major quality issue for this particular case is the clinical quality issues. Okay, what are clinical quality issues? Issues which are coming by the clinical and compromising actually towards the quality needs and not following the protocol, making more errors, and infection rates increasing or infection reduction is not done properly. Skills, education, investment, and again going back to OB science, it is like training the humans. Medication errors due to proper prescription and documentation is without a proper prescription documentation and eligible handwriting is not being considered. Variability in treated protocols and across department, no standard treatment guide is provided is also making more issues actually towards non-accreditations. High hospital acquired infection HI rate, especially ICU, lack of clinical and audit, which means that all those checks actually that we try for every patient, every department goes into the failure if your institution doesn't comes with a quality initiative. Okay. Inconsistent pre-operative checklist and surgical safety protocols, if though they are placed, you may have major reasons that your hospitals will come out of the different pending issues of your hospital that is particularly for quality. Delay diagnosis due to ineffective diagnostic turnaround rate is something where the role of diagnosis has plays major part into shaping the futuristic healthcare where most of the physicians, nurses are more reliable on the diagnostic part of that. Now comes what are the patient safety issues the hospital has faced. So if you try to understand the patient safety issue, and when I stated at the very start that do no harm or not hurting the patient or making it more clear or safer or at least no harming culture from the hospital, the patient safety issues can be handled. Otherwise, it will be something very deep diving. So identification failures were being seen as a one part in this particular hospital. Emergency delays were there. The reasons will be asked actually when we will come with the Q&A session. And adverse events reporting gaps. Adverse events, so they can cause, they may also lead you to irreversible change or they sometimes can give you death. So such sort of events are to be taken into note and event reporting is very important. Especially people who are coming from the government background, actually they might be knowing that in NQAS, when we study on the quality indicator part, it is always important that when you find that there is a great discrepancy that there is no DAMA case or adverse event case or near miss event, sentinel event or ADR, what does it comes into your mind? The reason mostly is coming like the hospital may have a very poor approach to the patient, or sometimes the issue stated over here is inadequate patient identification, name, band confusion, verbal identity. Okay. Delays in emergency response, which like no code blue drills, as if like whatever threat or situation comes or whatever the hospital will face in future with respect to their policy, they will not respond. Okay. So we were discussing about the different patient safety issues this hospital particularly is dealing. and more it comes like the hospital is coming with issues of identification failures and emergency delays and adverse event reporting gaps. If we talk about the issues which more points foreign hospitals to come, especially developing the patient safety culture, usually comes with the issues that a hospital tries actually to reduce maximum patient falls, also develops a culture to reduce for long stay patients, especially the pressure ulcers, improving the nurse protocols, making it more prone towards site identification and reducing the surgery risk actually, avoiding the near miss events, making it more towards developing standard operating procedures, SOPs, and also improving the clinicians' works towards reporting if though they come across any such incidents. So the hospital here is facing major issues with respect to patient safety for this particular case that we can identify. Then comes the patient-centric issues. The patient-centric issues mostly discussed over here is to be seen as waiting times. So long OPD waiting times average, where we talk about that the waiting times over here is being seen little more to the compared, and 45 to 90 minutes per patient, which is ideally not to be fitted, which needs to become more closer to 30 minutes maximum actually, if I have to see the footfall that can be handled and the major OPDs that a hospital is being facing. Where the bill transparency issue is more surprising to be seen that the price charges at a discharge, and there are lot of transparency issues where the patients, relatives, patients, and staff has lot of uh, issues in terms of dealing with the challenges actually that they are facing when they are leaving the hospital. Hospital also this is being found a little high in terms of the treatment cost that is giving the patient dissatisfaction and distrust and some sort of disagreement that the patients are facing. So it's like more not following the patient or pro-patient approach. Insufficient patients and family education on diagnosis and treatment is also not being seen, which is making more reasons that counseling, making more accountable healthcare, poor healthcare communication, and those are being seen as a very important problems actually the hospital is facing. One among the very major problem being seen in this is like language barriers with respect to the patients who are coming from rural areas or suburban areas or in the diverse metro populations actually, which may be seen as one among the reasons that lot of consent related problems or disagreements which comes more when you are not feeling the consents are being seen very much important over here, and which makes more reasons that poor healthcare communication may lead to lot of issues which are more of poor compliance, which is being seen by this particular hospital. The private hospitals which are perceived as expensive and profit driven, which is also being seen as a very important scene, which is very similar to the issue this hospital, this case study we are identifying for this particular hospital. Complaint mechanism being seen as, although otherwise is more a reason that private hospitals are being blamed, here it is also being seen as very much absent. And ineffectiveness in many of the facilities where the complaint mechanism is either nil or not being present, and where it is not even from the verbal or to the written, it is not being seen. Now comes what are the issues of human resources that we can identify. The nurse to patient ratio imbalance, often 1 is to 8 in general wards versus to recommended 1 is to 4 or to 6. Where it is being seen that we have to state it as that it is very important when you have to try to improve the clinical outcomes actually, the nurse to patient ratio balance gives more chances that there are a lot of delays and ineffective treatment, or you can say improper way of handling the patients, particularly near the IPD. Staff burnouts and high attrition, particularly among nursing staff because of overload or poor staffing, poor infrastructure, and all those which makes more challenges to the very important workforce in the hospital, where you can say majority of the workforce on whom the hospital's more majority of the clinical work lies on. Inadequate training on the quality protocols when the hospital is already on verge of NABH standards and safety systems and have already taken the major uh, imperatives towards NABH, the hospitals is having issues of quality, patient safety, even for HR part, and 58% of the nurses cite pressure to prioritize efficiency over safety, which makes something as the adoption of the quality philosophy is not being seen, and there is lack in training, which is more that accountability part is being seen as a major problem. Then comes the major gap, that is persistent no do gap. No do gap is something like a theoretical knowledge not translated into the bedside practice, which is ideally be saying that whatever you do in terms of your training, your skills, development of that in-house versus outsource, or all those which are being seen as a training component which the hospitals implies. But if it is not reflected when it is coming to the patients or patients' work, or not delivering to improve the outcome, it is a failure account. And very important, and to be very astonished to understand, there is an organizational silos where we say if the quality department is solely being seen only to take an effort, or the imperative of quality is only being taken by the quality team, whichever like 4 or 5 people or 8, 10 people, or even only people who are being appointed into the quality committee, then sometimes it becomes a major problem. And so where this hospital is also having the same issue, where the job of quality is being seen by only the people from the quality department and not by everyone, which is something very, very difficult to make the quality imperative to be followed. And where the hospital cannot really be seen to take this, or I mean to say, there is a poor leadership which is allowing actually to make this organization silos, because organization silos is not only because of the particular department or the people over there, but because of the implementation of quality which is not being seen over here. Lack of structured oriented programs for the new hires, people who are joined newly or who are on the temporary jobs over here or who have just been appointed. For those people, proper orientation programs are not taken, and which makes major reasons that the human resources issue, especially for nurses, where you find lot of attrition is there and high attrition, and the staff burnout. It may be even for the doctors also here who may even have faced this issue, which is being also one of the common reasons that private hospitals usually face. Now comes additionally administrative and operational issues. So, as you know, lot of issues of quality are being taken properly in communication with administrative. So, where we find hospital administration takes a major role in improving the quality management, especially for the operational part. It becomes very important where the administration identifies the administration is able to effectively improve these issues. The coordination failure, which is being seen as an interdepartmental or poor interdepartmental communication actually, which makes coordination and the communication breaks, which is resulting even to the patient's operational part. Documentation part, quality documentation becomes a very, very important issue, where you find a lot of your compliance, 70% compliance failures are only and only when your quality assessment, whether it is done by NQAS or NEBH, it will be failed when the quality documentation is due. Because whatever you do, it should also come on your paper. Whatever improvement your hospital is doing or you or yourself are doing, or even for a particular event that you are doing, it should come on a paper. If it is not documented, you have a failure actually that is expected. And so where many times it is being spelled that NABH is more into documentation, it is more in making you a practice that through documentation you can improve, because you cannot ultimately improve in one day. It is a slow process, and so where quality documentation plays a major role over here, where you can identify, you can analyze, you can make it a way actually to improve. Okay. And inefficient discharge processes, which is being resulted where the average discharge, which should not be more than 2 maximum, but it is being seen the average 6+ hours discharge time has already crossed actually, and it is more being seen that the hospital is on the verge of a very decline of poor discharge conditions, where the standard, or I am to say a very prompt actually, which is more like a planned discharge, is not being seen over. Bed management challenges, no real-time bed tracking system, and over reliance on the verbal communication being seen, which is, although otherwise is very common, but is not the one, a very standard communication that we should rely on. That should be again major role of non-verbal versus verbal communication, which should be made more a confirmatory communication, which should improve the clinical outcomes. Delayed pharmacy dispensing due to manual prescription workflow, which is not that the hospital is not with a system approach, and lot of delays will go more in identifying sometimes if there are challenge of prescription errors, or sometimes more load on there, or even the distance and locations and the linkages of the pharmacy to the IPDs or OPDs. Lack of clinical decision support in outpatient settings is more because of insufficient staff, lack of skills, role, appointment system, and making it more towards a disease condition, which the referral part also, which gives more reasons that this hospital is more facing the problem of outpatient settings. Now we'll talk about infrastructure and financial, which is more very imperative that lot of hospitals which are facing, especially we are talking about corporate hospitals, which are failing is more because of lot of overcrowding in the emergency department. And when you find your emergency department is not able to handle, the major rejections goes, and the hospital face lot of problems where sometimes a patient die in the emergency department, or sometimes the shift and the transfer or referral is not being done in a proper way. Equipment downtime, poor biomedical maintenance actually, which is making more reasons that your hospital have improper biomedical engineering management, either because your contract is not good, or you don't have a well dedicated biomedical engineer, or your infection control lapses because of proper or improper ventilation and sterilization, the protocols either in the CSSD or ICU or OT and all those places. Not only into this, but even the entire hospital requires infection control practices, prevention practices, which is not being seen. So you may find a lot of infrastructure issues are contributing actually to this, where fire safety is linked, the inadequate signages and patient flow, which makes major reasons for improving healthcare communication and improving the compliance, or sometimes the power backup failures, which are more responsibly causing the critical care services, which is majorly affected in the hospital. Financial part, overuse of diagnostics, unnecessary investigation, which is a very poor and a very bad practice. Insurance related delay where the TPA might not be properly shaped or faced, and the hospital is not more towards the insurance patient, or not provisions of the health coverage that the patients are expecting. Ethical dilemmas, where the profit versus quality care balance is very important, where it is find that the hospital is more towards a profit orientation, where the quality is compromised. And we find that a lot of unpredictable billing, which are causing financial toxicity to the patient's relative, and also making more problems to the hospitals, where lot of conflicts comes, where the pressure ultimately will go on the healthcare staff, nurses, doctors, eventually on the clinicians to achieve revenue targets, which makes a lot of tussles, and the hospital's image is being in a short. And lot of transparency in pharmaceutical types. Actually, you may find that unnecessary medicines are written, or even the pricing is a discrepancy only. So now what we need to do over here, we are principally using RCA here. We are taking root cause analysis, and we are trying to understand what are the system drivers behind the persistent quality failure that this hospital has faced. So when we are trying to understand what are the major real reasons that has happened to this hospital, why this hospital has faced the issue of quality here, and what is that the different departments that we have seen, or the issues that we have seen are more being seen as. The major part over here is coming as the medical. Suppose you take the medication error as one among those, you may find that immediate like wrong doses no, might be seen, because when you take RCA, You will go into the depth on understanding the system failures. In this particular hospital, the very first and very important system failure was that lack of standardized protocol. The hospital is not having standardized protocol. There is absence of standard treatment guidelines, which is needed to be created to improve, or I mean to say, to chase the clinical chaos. And the variability is being seen in the care outcomes, which is delayed or poor actually, where lack of standardized protocol is one essentiality, not only for this hospital, but the similar hospitals which are facing this or the common issue. As a quality professional, you need to understand that this is one area where you have to focus on. The second is the weak leadership. Weak leadership already have spelled about, where you find the inclination from the leadership should be there to improve the quality improvement gaps actually which the hospital is facing. The top-down approach rather not the down-top approach, where the reason is being seen where the ownership and the weak leadership stalls not to change, but is trying to make it more weaker and weaker, which will give the hospitals to have ultimately a lot of failures or even change in leadership of, or even the hospital may get acquired. Insufficient staffing training actually, where the staff is very poor or they are underpaid, or many times you may find that there is a gap actually in what really they have learned or they have acquired and what they are really applying for. And resource constraint, which is also being seen very commonly as all major of the Indian hospitals, private hospital, government hospitals, they face limited budget for safety tools, training, infrastructure, which are major reasons. Where your safety tools will play major role in improving the quality. Training, which is very, very important, and the basic fundamentals that the staff is failing more because of poor training, not understanding. And infrastructure upgrades, which will make quality more sustainable. Okay. Resistance to change. Even though after you all improve all these things, and if you find that there's a cultural inertia that the hospital employees are not well motivated, they are not inclined, or they are resistance as if like old generation, or sometimes they are more worried or hate or because of a lot of documentations, and sometimes the newer protocols which are being brought. So where you find lot of resistance to NABH is also being more being seen, because the clinicals or clinicians, doctors particularly, super specialists, specialists, surgeons, your physicians, they have a lot of clinical inertia, and they make it more as their culture, and which ultimately brings the cultural inertia, which makes that they don't want and they resist it in a group actually, which you find that most of the time the hospitals, everyone is ready to follow, nurses are ready, other healthcare group, but the doctors really they don't want to come up into improving the quality, as if like quality doesn't matter for them. The fear or blame culture, when you report something like a near miss event is reported, or adverse reported, ADR is done, or even sentinel reported, mostly you find that the incident happened but it is not reported. There is a lot of things which are put under the carpet, which makes a reason that if you point out, if you raise it, there is always a blame culture, because quality always is to be seen as an hampered only because of blame culture, pinpointing towards the soft targets and making that incident reporting is not done because of fear of blame. So what a RCA has done, or the RCA has given some recommendations that we will be spelling about when we are doing the RCA. And these are the reasons that which are being identified. And poor IT interoperability. Many times it is being seen that why IT is to be seen of transferring, and which is making that it can reduce the critical information or delay which are happening in the clinical also can be reduced with the IT. IT makes more reasons actually to improve your information in time, can see that your clinical decisions or decision making is more being improved because of the IT involvement. And IT interoperability, if it is a poor, actually it makes a reason that you may identify one a very important way that you can handle it in a proper way. The root cause analysis, particularly over here, has given some categorizing responses, which is more like when we come across an issue of quality failure in a hospital care, what we need to do. And here, particularly, the major reasons which are pointing towards a human resource, particularly for the manpower, is like seen nursing shortage as a major reason, training gaps, which is very, very common in all the threads that we are discussing till now, and the burnouts among the healthcare workers. So if we are pointing towards the three major issues, you will get more good solutions to deal with. And so where your quality improvement or quality management cycle, where your quality planning, quality continuous improvement and quality assurance, the trilogy of Jurans will be completed. The second is your machine part, your equipment part, where we find that equipment downtime has to be improved, where your biomedical engineering services, your biomedical management has to be improved. And you should not get complaints actually, which, or you should be towards more towards your maintenance, that it should be done properly. Or you should try to revise what is your vendor really giving you more reasons for. Okay. In terms of improving the processes or to give it more reasons that how you can improve, standard treatment guidelines, which have been seen that no standard treatment guidelines, you have to make sure that you have to make the standard treatment guidelines. The weak RCA processes which are being pointed in the previous slides actually have to be improved, and those improvement will slowly lead to give you more chances of improving the health outcome, and indirectly you will say your quality management problems will be solved. Ad hoc audits actually, where you can say you can do it at your level, you can put people, external agencies, or you can even hire, and you can do some audits actually which will improve your work. Otherwise you cannot just say that you are good at your work or you are the best at your work. Someone need to assess it. Either you need to have your own quality team which is well developed actually to make it more sure that you are more improving, or else actually you need to hire and make these audits. Ultimately, when your quality team from NABH will come and they will understand that you will have all these issues, there will be a poor outcome, and the evaluation will be ultimately resulting to failures. Now comes to material part, which is very, very important. Drug shortages are being seen in the pharmacy, consumable lapses which are being seen from the different department, and counterfeit risk actually, which is making more that the hospital has to take more reasons that the management should now come as a base and fundamentally to take into shape, and the weak management, weak leadership, which is being seen to have all these reasons of the RCA being seen, are more because of that. Revenue, which plays a major important role, even though sometimes you may have a silos culture or a cultural resistance, you can handle it. But if though you have a weak leadership and poor revenue or support, ultimately it will reduce the quality. You will get a major problem of quality only and only because of these two major reasons, actually, which is always a killing approach towards it. So, what is the quality management framework that is being adopted? The NABH recommendations from the Donabedian model, and when you are tracking the Donabedian towards the Juran's trilogy, making it more an efforts towards even leading that what advancement NABH has brought, and the NABH 10 domain standards for quality, and making quality towards improvement and assurance as in giving a continuous quality, it will give a holistic standards which is well fitted not only to this hospital but a similar problems that the hospitals will come over here, where assessment and continuity of care, which is being seen as a very first very important domain, the care of the patients, where standardization is more pointing, which will state that when you are more expecting towards the continuity of care, or you are giving an access more improvement, the care of the patients, because they are all interlinked, where the medication management, IPC, infection prevention and control, patient rights and education, where you find the incidence of even healthcare communication, which is being poor, HR management, HR management trainings, emphasis, which is pointed, management of information, where you find technology related issues. So all these 10 domains are more taking issues from facility management, safety, quality improvement, all those which are more pointed towards improving the overall clinical and non-clinical, that is organizational quality, which will give you the major reason that NABH handles through all the 10 domains a holistic frame actually, which gives you more reasons that overall safety will be taken care of. So what are the tools that you have to see that even though after understanding it through the RCA, you are applying NABH now, you are trying to take it more that you will put up the advanced tools that you are more practicing, because it is not that these are the only, but these are the one very popular and very important quality tools, evidence based, because evidence based tools, why I'm saying it is something like it has a reason, it has a full-fledged evidences with lot of institutions who have benefited by this and who have taken, not only because they are being practiced singly or they are being practiced in a group or they are being practiced with their results. I can say this all is one reason that it is not that always you can only solve the problem of quality management with only one set of it. So out of all the six, you can have majorly you can pick up the first two, which I have given particularly for this hospital. As a quality management professional, I can say PDCA and Six Sigma will solve the major problem for you. But as you have already done RCA, you know what is the major issues over here. So what is the problem? The PDCA will do the plan, do, check and act, which is a very important cycle and which can be, I think this hospital issue can be solved in one cycle itself. You don't have to repeat PDCA over here. Many times if the problem is very chronic, it can you need to repeat it also. So this is very iterative quality improvement tool, and reducing the OPD waiting time can be one reason that PDCA can be effectively being seen very, very importantly that you can solve the major problem. Reducing the waiting time itself will improve most of the processes over there, and most of the hospital for quality, if you reduce one among the patients feedbacks, if you find are more towards reducing the OPD waiting time. Culturally, you can start to see the quality improvement from this one specific problem. Second is like the demand, the Six Sigma, where you find that you can define, you can measure, analyze, improve the quality. The major reasons for this particular hospital is like reducing the medical error, prescription error, delays in transferring the information, and especially when the patients discharge, the patients are not able to understand towards the clinical outcomes, the price, the cost, and the delays. So the follow-up will also be disrupted. The fishbone or Ishikawa diagram, which categorize from the manpower, methods, machine, materials, and management, where all the bones over here are more flattened, and you may find more or less the issue here is of HR also, methods also, biomedical, machines also, equipment maintenance, materials also, and management. We have already shown into the previous cycles also. Yeah, you may find it over here. All this we can put it and improve into the Ishikawa fishbone diagram. Now comes the major important issue of quality, the benchmarking. Comparing the key performance indicators that we have pointed over here that we should improve, or if at all indicators are to be augmented or added with respect to achieving the NABH requirements or JCI, which is little more promising. But if this hospital is taking NABH accreditation and making it a great improvement, which the hospital is expected, and the hospital needs to take, because this particular hospital is lacking with lot of major issues. The NABH is the need over here. NABH will give a continuous improvement. NABH will solve the major problems over here. If though after completing this, what comes as a very important and the last thing, if you are trying to take this tool, you should not forget that this hospital is having major problem. So clinical audits will improve the treatment protocol, where the standard treatment guidelines actually will also be in reviewing this treatment. Because without reviewing, you will not understand what is the improvement done. Reviewing will also follow by feedback also trying to understand the gaps, working on those loops, which ultimately will result to the clinical governance. Clinical governance, no doubt, is only not the responsibility of the HODs or by the specialist or super specialist, but even it is by the RMOs, the nurses, registered nurses, even someone as we can say the the team actually who is involved into improving the clinical outcomes of a patient and not only the physician who takes the major roles. Now comes on focusing the PDC and Six Sigma in detail. Most widely used quality management methodology in hospital settings, and particularly for this hospital, we require this. Where the plan do check and act, where the PDCA usually comes up, actually, we talk about for this where it is being seen very important that you have to identify the problem. What is the problem when you are starting to take a PDCA, when you are trying to take one PDCA cycle to do? Set the measurable objectives. Actually, you cannot complete the whole problem. So out of that problem, you have to take one or two or three which can be achievable. You have to do a design intervention where when you understand that this is the problem and you have already set an objective for that, in what intervention or what set of thing actually this can be done. Whether it has to be a time limited, whether it has to be people involved, whether the resources are part over there, that can be done. And then comes the very important and the very mid part of PDCA, that is do, that you have to take it. Whether it is a pilot phase that you can do it, the intervention, or you can take it in a continuing part. You have to even check what the intervention is done by measuring the outcomes, comparing it with the targets, or making it with the comparison with the baseline. And finally, after completing that, you have to act, that you have to make standardize it if you find that it is successful, and recycle it if you have find that it should be continuous, or you have to do again the PDCA if you find that it is unsuccessful. I can give the example for this particular hospital. If you reduce the OPD waiting time from 90 to 30 minutes over the 6 months, you may find that slowly the hospital will come into the very standardized OPD time reduction, and the hospital will ultimately see the results. Advantages like very applicable to the ward level without large investment, and you may find this as being seen as a very important way of dealing majority of the quality management issue that transfer from OPD to IPD, improving the patient's outcomes, even communication, and so lot of things where you can find the advantages, very simplest way of dealing with this issue. If we talk about taking Six Sigma, which is something not complex, but something like a time consuming, where you have to take it in a form of a project to this particular hospital. And this particular hospital will require a DMAC, okay, where you can say that a define, measure, analyze, improve, control, and target, which is more towards understanding that in the case of PDCA, it was identifying the problem. Here, identifying the problem scope, whether that problem can lead to what? Medication error of 34%, or sometimes discharge delay of more than 3 hours, 4 hours, or 2 hours. Okay. Measurement, quality current performance using the data collection, where you have to do intense data. At least you need to have a certain set of a sample, as if like you are trying to do a study which is more towards improving the quality. Yes, it is. Analyzing the statistical tools, because Six Sigma is a statistical driven exercise where you need to improve on reducing the wastage or identifying the root causes of the defects, and you have to slowly improve. Improvement will come for a design solution, might be barcoding, bar scanning, e-prescribing, or even putting e-prescription. A lot of things can become. But rather doing this, I would like to say that this hospital doesn't even require more rigorous Six Sigma. Either one of the 2 or 3 level of Sigma also can solve, where I find in this particular hospital, the dashboards are not there properly. SOPs are very poor or not taken. So you will find that the reduction will be very strong, and you may find a drastic improvement in this particular hospital's workflow. Now comes to the final solution and strategies that you all are expecting, that what are the evidence-based interventions and what the domains that we have studied and that NABH focuses on all the 10 domains, and what are the 7 domains mapped across where we find that the hospital can get a remarkable change. Okay. So clinical governance, standard treatment guidelines, clinical audits we have to do, and evidence-based medicine practices, which will be giving clinical governance as a prime role, where in the 7 domains we put clinical domains, clinical governance at the last. Patient safety, no doubt, we have to put it in a priority. So I put it into the second line, barcode ID, incident reporting, and RCA. So if you do all these things for this particular hospital, you may find that the quality will give you some of the best features that it can give to improve to this poor hospital, making it a very good hospital. HR, we are asked them to put it for the CME, ask them to go for a CME. NABH training, they have to be given from the grassroots to top managers. Performance appraisal needs to be there. You have to improve in terms of when you have to pay to your employee, then only you can see the quality. Patient experience, digital appointments, you can streamline. Transparent billing, where you have to understand the concerns of the patient, and feedback system to see that how you can improve the relationship with it. Operational efficiency, lean management, where maximum reduction into the errors. HIS, which you have information system, healthcare information system, hospital management information, HMIS, streamlining the discharge. And very important and a very standard way of handling this, infection control practices, hand hygiene audits, antimicrobial stewardship program, rational use of antibiotics, and sterilization. Financial transparency will boost to make this hospital more free towards using all the resources optimally with respect to quality and safety. Clinical governance has developed, and you may find that it has reflected, which has established with the developed and implemented SDGs for all the departments, established departmental clinical audits with monthly reviews, which has given more a reason that the hospital is more seen that clinical governance has shaped the entire thing, and reduction into the mortality and morbidity by reviewing meetings by the HODs and working on the adverse outcomes. Clinical pathways developed by not only making more high volume conditions or working on those issues that are affecting the hospital more, like surgical site infections or even VAP or even UTI and all those sepsis and all that, but working on the reviews which are being coming from your laboratory, your microbiologist, your pathologist, your quality team. Patient safety interventions, which is one way this hospital which we have done is deploying the barcode based on the patient identification. Electronic incident reporting system the hospital needs to adopt because it's not a one-day task. And what the RCA has recommended, it is more towards improving uh, the operative challenges, especially for surgical safety checklist, which is not that WHO, but even you may find a recommendation of having a surgical safety checklist is something which revamps actually the hospital needs, and the hospital gets a major reasons to give you the evidence-based care. Regular code blues, which is more for all the emergencies that the hospitals will come, for code blue to code pink to code red, and all those where even your safety is also priority, making hospital more from heart to all other emergencies that hospital handles needs to be taken care of. HR improvement has been seen with the recommended things, NABH orientations, dedicated quality coordinators, which has given more streamlining, and you may find the hospital is improving. Patient's experience also on the other side you may find as being seen well taken care of, which will resultantly seen into 6 to 8 months that it will give you more benefits, and the patient's compliance will be increased. Operational efficiency by lean management, no doubt, will be taken care of by value stream mapping, and HIS integration will give reasons actually to see that how what changes that we have brought will be result of seeing that operational efficiency will make more reasons that whatever infection prevention you are trying to take is very well connected actually with those efforts that a hospital is taking with respect to designing actually whom you need to take up, and what sort of challenges the hospital has faced is more because of your operational inefficiency. Infection control, already as I've stated, working more on hand hygiene, antimicrobial stewardship, rational use of antibiotic, CSSD, taking more reasons that your CSSD should also be coming into quality lens, HAI with reduction in the hospital acquired infection, all those from WAP to your COTI, and even the central line associated infection. Biomedical rules, and very important that you need to segregate, you need to have more trainings, you need to have signages, you need to understand the proper waste segregation, training protocols need to be followed to from all level of employees. Financial stability, no doubt, ultimately, the transparency will improve your patient trust, and the hospital will get more value. Image of the hospital with respect to admission, follow, and the patient rights when you are taken handled, it will give a more ethically way actually to deal with all these issues that your hospital was facing will be solved. And many times you find that hospitals are more being handled with trust and transparency hand in hand will give you more reasons that your patients will get more satisfaction, rather the patient will quarrel or will have disagreement with respect to the accountability and fair pricing problem. Now finally coming to the impact of the NABH and the discussion that we are making, why NABH is giving you the reason. NABH has impacted. Now the results is being showing that the studies shows that NABH reduces HAI now from 2.8 to 1.6%, which is 42% reduction. Medication errors, 35% of reduction, which is very drastically showing that medication error reduction with NABH takes a major role. And the baseline for patient falls with 40% reduction is a huge, which is very closer to the 50%. Discharge time from 6 hours directly to half, that is 3.5, closer to 42%. Patient satisfaction very improved by plus 10%, and patient volume also has seen drastically improved. KPIs, what are the KPIs that we have done? Hospital infection rate actually, which is like you may say associated acquired infection rate has to be taken care of. And the major KPIs that you will put for clinical will see that you will be able to work statistically on that, and your decisions what you take, whether it is a medication error rate or average length of stay, all those can be seen. And plus in addition, if you take more, you will find that your KPIs, the more the KPIs properly handled, the more the KPIs work, where you will find there are door open towards more of progression actually towards understanding the quality. You can take down and you can even work on this KPI at your institution. Not only that, this hospital is one who is where we have to put all this, but the KPIs for all these issues, where you say the bed occupancy rate, you may find that if you are working on the bed occupancy rate, particularly for understanding that why a hospital bed occupancy rate is very poor, and with respect to the service offer, you may understand there is some reason, and your RCA will give you the answer of this. If you find your OPD waiting time is something very high and it is very much poor in terms of the patient's feedback, then if you're working on this particular key performance indicator, you will drastically see the clinical part getting improved. Okay. Recommendations at the last, what are the actionable steps that you have to take? Pursue NABH accreditation. No doubt, actually, this is a discussion that is going more closer for the NABH, and that's why I'm saying they initiate gap analysis, working as a team. Actually, those who are more towards or hospitals, they need to understand that NABH is not that it will come into days or even in months. It will take some 2 to 3 years slowly that you can adopt the NABH culture. Implementing HIS is one a need, and it is a need of not only of future, but it is a need to make your hospital more towards the uh, integrity, and also to make your hospital in aligned to the government's requirement of Ayushman Bharat Digital Health Mission. Also, strengthening the IPC, where Infection Control Committee and the prime role to work with the Infection Control Committee with the quality. developing the standard treatment guidelines, also making that your culture in hospital, organization culture, also climate is very important, where you can build a safety culture where patient safety itself is a priority, but non-punitive reporting culture, making your employee work life very important, that you should invest in your staff training, digitize and automatize the hospital, which makes more reason that your hospital will have a safer and a better practice, which ultimately will give a more patient trust and ethical reasons for a hospital will be seen by. The recommendation points towards the strategic priorities that are made for this hospital, which is a quality transformation. Okay, it is not that it is like giving you tactics which are only for a few days or few time, but strategies which are more pointed, that out of these few of the strategies are long term and majority are very short term strategy which can be fulfill your expected outcome. In conclusion, I want to say that quality is not a destination. Ideally speaking, quality should be a continuous pathway, and healthcare, especially we have discussed today about a private hospital, a hospital which is a tertiary care and very big hospital. And you find that a hospital also has evolved and the hospital has invested. But in India, we find hospitals particularly are going with an evolving phase. A lot of transformation is being seen with the increasing burden of infectious disease. And in addition, Indian hospitals are facing load of even non-communicable disease also. Okay. Your hospitals, Indian hospitals are saying, are evolving through that transformation. As if like I'm saying the healthcare, particularly in India, is in a transition phase. So while NABH being seen as a very principal and very important accreditation agency, actually, which is very powerful in structurally being seen as a very important framework that can be adopted, no doubt there is a cost which is very important to be seen in NABH, and very importantly, in the realistic and a very sustained improvement manner, NABH can take the dependency that is hospital, and not only this hospital, even the private hospitals which has an increasing demand can be faced. In conclusion, I want to state over here, in addition, is like the leadership commitment, not only for the clinical governance, but even to see that the top management in the hospital must own quality and should not take the quality only because the hospital is getting money or the hospital is not getting. So hospital leadership, top leadership, not delegate it, but they implement it. They go, earn it actually. Second is like the staff engagement. If your hospital staff is not taking the responsibility, everyone in the staff, every person in the hospital, from the down to top. Okay, your decision for everything in your hospital may be from top to down, but adopting the culture of staff engagement and teamwork needs to be coming with the responsibility that you are taking. As if like it's a work actually to be taken not at department level, but as a holistic level. Okay. And the third and very important recommendation, continuous monitoring. Even though you are doing your work properly, even though you have a top management, even though your top management is investing, but if you are not monitored properly, if you are not assessed, if you don't have a dashboard, if you don't have an audit, if you don't have a kappa, that no one is being seeing you or no one is even rectifying your work, you will be something like a child actually who is really being left over by the parents, and there is no parenting. The child may do a lot of nefarious activities, will land up to give a problem to their parents, or sometimes they may have. And so where we find hospitals who are not controlled or not being monitored properly, they land up into quality issues. The last which I'm trying to say is like a patient-centric approach, which may be find little promising, or sometimes you may say it's very ambitious approach, but yes, it is very important. Indian hospital need to see very important patient-centric approach, because ultimately the hospitals are run only because of patient. It is not that hospital want to earn, the hospital need to work more on the patient welfare. Okay, the hospital's every decision must start and end with patient. As if like you need to see that your patients are the one as a top approach. So quality is equal to patient centric approach. And additionally, for the future and futuristic hospital, that in future that we will be seeing that hospitals are evolving, and the city that I've quoted over here is like Delhi, particularly technologically enabled. If I've even seeing all the other top metro cities that in your country is, everyone is more pro towards the digital health. The digital health part, which is improving with the efforts of the government. Also, digital health part is also helping us to remove the manual errors. Lot of manual errors, technical errors, which are more because of the human skills, are more handled properly. Sometimes not every time by the technology. Sometimes technology also can fail. It is human to handle it and human to improve it. So you can say the traceability part, digitalization is giving human more reasons to be more perfect. Okay. So technology should go hand in hand with the human not going ahead or technology not going ahead. So I mean to say the word what I've used over here is technological imbalance, no, or the technology which is making or enabling actually humans to work more properly. Lastly, to see that your hospital is evolved, your hospital is transformed, you have to see that you imbibe the culture of learning. Quality is not a one-day cycle that your hospital has achieved and you got a certification, as if like 10, 15 years, 20 years, your hospital will not have any work. No doubt, quality is always, just like what we require is a food every day or to breathe like an air every moment. Quality in hospitals is like inevitable. You have to take it every task. See, hospital is not like a product industry or a manufacturing industry that you can only concentrate on getting a proper product. Hospital is a world where your product is your patient, and patient is very unpredictable. Patient is very uncertain. Patient is very impatient. So your patient may give you adverse event anytime. Your patient will give you any ADR, adverse drug reaction. Your patient may give you anaphylaxis. Your patient, not you. I'm saying the patient may create a situation that it will give you anaphylaxis. And there where you need to work on improving the learning opportunities to reduce this. Okay. See, you don't have to come up with a blame culture that this particular person has caused this person reason. Ideally, the people who are in the soft targets in the hospital are the nurses, are the other healthcare professionals, and who are the one who resist more into the hospitals of not adopting the culture of quality. It is more with the top clinical governing people, that is the doctors. So learning culture to all people, it is like assembling, adjusting, and improving. These are the three mantras that I can see that when you have to see the culture of learning, you need to take up ahead with this. So with this, I think I come an end to this, the important additional information that quality management issues in Indian private hospitals we need to take is more like Indian quality management hospitals should come up with accreditation. They need to be very pro in adopting at least NABH, and slowly, if they have getting the clientele as an international patients and all that with a lot of medical tourism that is going on in our country. With respect to the cost, because quality also needs to get a cost actually. Okay, so they need to go with accreditation. Medication errors, because Indian hospital face lot of issue of medication errors, because we have top doctors, we have top teams, but we are very irregular. I mean to say very irresponsible, and we are more with gaps in getting updated. So medication errors are not only human cause. Medication error is more like a medical comprehension, as if like you have to get updated. That is one reason I can say medication errors are more a reason. I'm not talking about prescription errors. I'm not talking about drug doses or administration that are more in align and more I can say the second line, no? Medication error altogether, as if like the major reason of medical negligence is only because of medication error. There are many other reasons of medical negligence also, but this is one of principally constituting which Indian hospital. HR gaps are very being seen in Indian hospital. Understaffing is there, not properly skilled and properly educated, which is making our organization silos. Digitalization is extremely poor. Very few hospitals are digitally transforming themselves, as if like Indian hospitals are in a verge of digital, I can say, emerging era, where you can see the other sectors in our country have already taken digital. We are par exceeding over there, but in hospitals and healthcare sector, we are very lacking and we are very poor. I have given you in a number of references over here which can be cited. which can be taken when you have reading for this particular topic, and when you are making efforts actually for your exams, particularly after completing this module, when you will be taking, you need to revise this, and you need to see up, if though you have any query, you can drop down into uh, the chat message where you can put, we will be addressing those queries. You have one more session actually, that next time I will be coming for this live session like this, where we'll come up with a case study which is more coming from NQAS, particularly for public hospital also. So we'll try to take maximum revision after completing all the sessions that you have seen, all the 60 sessions, you revise it and then you start preparing for this case studies. Okay. So this will help you for your next uh, month exams that you will be facing, which will be coming with all the discussions that we have taken. Okay. So with this, I conclude over here. So thank you. Thank you very much for attending this session. And if you have any quick doubts, query, you can type it or you can address it. I will try to address those. Thank you so much. Okay. So I will stop sharing over here. This recording will also be uploaded and will be shared. And even there will be an attachment of giving this presentation also. Okay. So thank you very much.